and save our hospitals. And I wanted to say thank you for the AGM, and it's like, let's start with something positive. It's fantastic to hear about the standardised mortality rates, and that's a really good measure of brilliant care in Imperial, and you know that's something that we can all celebrate. Having said that, I want to sort of challenge a little bit what I thought was a degree of complacency really around A&E and waiting times, because actually the Trust has breached A&E waiting times pretty consistently since the closure of Hammersmith A&E. And I think that the stats that you gave, Tracy, are a bit disingenuous because they merge both urgent care and the very acute care, and actually it's the people who are very ill, the most acutely ill, who are waiting the longest. First of all, they're waiting longest in London Ambulance Service. They're really breaching their targets, and only around 65% of the most ill people are getting to A&E with it being seen within 8 minutes, which is the LAS time. So that's very worrying, and something that we were told we ought to be able to rely on good ambulance services as part of the A&E closure plan. But secondly, they have some of the longest waits in A&E. And whilst it has improved, I'm looking at the CCG, Hammersmith and Fulham CCG reports, and they rate the problem still as a risk. They talk about how the improvement hasn't been sustained, and I'd like to say that if it's got better but not even reaching target now, in the summer, it worries me how things will be in the winter. And the other thing is when you look at the reasons the Trust gives for why they miss waiting times, they talk about staff shortages, they talk a lot about bed shortages, about not having the right kinds of beds, the level of dependency and monitoring and so on. And when you actually look at the detail, it's not quite as rosy a picture as Tracy painted, and it makes me think that you ought to look again at your plan to close 300 plus acute beds at Charing Cross, given that bed capacity and your ability to deal with the most acutely ill is already quite compromised.
Okay, thank you very much.
So in terms of dealing with this question to Richard, perhaps Steve, if you want to talk about the A&E.
Oh, well, thank you. So I think a really pertinent question. I think the first thing we would say is we're absolutely not complacent about this, absolutely not. So I think you have seen that improvement since the period last September, and within that overall improvement, we've also seen an improvement in terms of the waiting times for, as you say, the patients who are the sickest, who are being brought to our A&Es. But since that time, and being able to consolidate our services in terms of the two A&Es at St Mary's and the Charing Cross, we've been able to increase our consultant cover, so your point about recruitment, so we've been able to increase our recruitment of consultant emergency department doctors from 17 to 24 now. So we have got much better cover across the 24-hour period into the evenings and weekends for our patients, our most sick patients who are coming to both of those emergency departments. We've got further plans to extend the ambulatory emergency care services that we've already put in place, and so they will be extended as we go into this winter period to 7 days a week. And we've also increased the cover for teams such as our discharge team, so that we can help patients get home and out of hospital, not just Monday to Friday, but at weekends as well, which again helps the flow of patients through our hospitals on an emergency pathway. So I think we take your point there, but I think it's really important to get the message that we're not complacent. And as we go into this next winter period, we are and will continue to redouble our efforts to make sure that we're delivering fast and effective treatment for our patients coming to our emergency departments.
I know there's plans for it to move, so I was very surprised to see on the website that 2 of the theatres are being done up, so I wondered how this was happening or why.
Thanks very much for that question, Rose. You're quite right, some of the theatres at Western Eye are being done up at the moment. We have quite a need to continue to maintain the infrastructure of all of our hospitals. So, as Richard said in his presentation, quite a lot of the money that we spend in terms of our capital money each year is on continuing to maintain our facilities, because whilst we're awaiting some of the more significant capital changes across the trust and the funding for those more significant capital changes, we need to make sure that the equipment we're using and the facilities that we're using remains fit for purpose to treat and manage the patients that we're seeing every day. So that's why we're continuing to maintain those theatres at the Western Eye Hospital, and that's what that upgrade is about. The longer term plans for Western Eye Hospital are, you're quite right, to relocate the Western Eye Hospital and its services to the St Mary's Hospital site.
Hospital. Now, 4 years ago, at the age of 80, I needed a knee operation, and they wanted me to go to Charing Cross. I refused, and I had it done by Mr. Spicer in St Mary's. It was marvellous. 2 days, 80 years old, I was able to walk with just a stick. Now, I may need surgery on my right shoulder. I'm now 84, and I will not go to Charing Cross Hospital. So my question is, am I likely to get it, the offer of the operation being done in St Mary's if I need it? Because if not, I should go to UCH or somewhere else.
You don't go to UCH.
It's been nearer to me. It's only one bus. To Charing Cross, it's 2 buses, take me over an hour, and I absolutely refuse.
So I'm really glad you got to ask that question. We had a chat before we started. So I think, as I explained, we provide orthopaedic services across our Charing Cross site and our St Mary's site. The orthopaedic services that we provide at the St Mary's site are more geared towards trauma, but we do have that flexibility in terms of the services that we provide on both of those sites. So in terms of taking your particular needs into account, we'd be very happy to look and work with you as a patient around your individual needs to try and make sure that we can get the surgery that you require once referred to us at the right location. But we do provide orthopaedic services on both sites.
I'll keep my fingers crossed then, thank you.
Yeah, my name is Suzanne Steer. I'm an outpatient at Charing Cross Hospital. I was very concerned about the possible closure of the lymphedema service at Charing Cross. I wrote letters to the staff, and I can't understand why it's not being financed by the trust, but it's done by Macmillan and St John's Hospice. So therefore, the only people that get the treatment are if you live in certain boroughs like Westminster, which I do, Hammersmith and Fulham. And yet the results of the operations for cancer and having lymphedema is as a result of the treatment that you're receiving by the surgeons at the hospital. I just don't understand why it's not being financed directly by Imperial College, so that everybody who's treated at Imperial within the Imperial College Trust can't receive the treatment.
Okay, thank you.
It's a lottery.
Janice?
Yes, I've noticed in the audience it might be best to get the clearest answer. Diana Arlenas for Cancer, who's been dealing with this joint service with John and Liz's, has just got a microphone, I think, at the back. Do you want to just talk us through, Diana, situation?
Yeah, sure. Hello everybody, my name is
Shout up a bit.
and I'm the trust lead cancer nurse, and I was fully involved, actually as was Sarah from Macmillan, with the lymphedema service. And we were in a position to fortunately get some funding in the initial stages for a pilot that was sponsored by Macmillan for our lymphedema service. That was extended. It was originally a year-long pilot. It was extended by a further 4 months, and it was run in conjunction with St John's Hospice, and continues to be run jointly between the nurses at Charing Cross and St John's. But as I said, it was a pilot scheme which was then fully evaluated. And working with St John's, we have worked with commissioners to actually commission that service. So we now run for a majority of the CCGs a fully commissioned service and we also run assessment for all patients that come through our cancer services via Charing Cross, and they're then fielded out to appropriate other services for those that are not commissioned with us.
With patients and local communities. On page 8 of the report, there's a picture of Charing Cross Hospital and no indication within the text beside it of the cuts which are being planned for that hospital. When is the Trust going to start being a bit more honest and open about its intentions if it wants to gain the trust of the local community?
So thank you very much for that question. You're quite right, we've got quite a significant clinical strategy across the Trust. That clinical strategy talks about what's proposed. I think my lapel might say, yeah. Can everyone hear me up the back?
Yeah.
Yeah, great. Our clinical strategy talks about the role of each of our main sites going forward. So the role for Charing Cross Hospital being a local hospital in the future, the role for our Hammersmith Hospital site being a specialist hospital going forward, and the role of St Mary's Hospital being our major acute and trauma site going forward. So that plan is very consistent and actually forms part of the broader plans across North West London about how best to configure the services across North West London to provide the best care and the safest care for our 2 million catchment population across North West London. So our plans are very consistent with those plans that were agreed back in 2013 by the Secretary of State after the independent panel review, and our clinical strategy that the board approved last year, which is up on our website and went through our public board meeting, talks entirely about those plans for Charing Cross Hospital and for our other sites that are all part of the overall clinical strategy for the Trust. In terms of the timing of those plans, you might remember in our July public board meeting, we also talked about the need to do a business case, because to implement those clinical plans, we need some significant capital to upgrade each of our main sites, our Charing Cross site and our St Mary's site in particular, and to be able to relocate the Western Eye Hospital across to the St Mary's site. We're working very closely with the other providers within North West London and with our CCG, our commissioners within North West London, to put together that business case to bid for the capital to be able to do the redevelopment and reconfiguration of our sites to implement those elements of our clinical strategy. As soon as we've had that business case approved, then we will be able to spend more time with our community talking about the timing of those plans and how we will plan to do that reconfiguration across each of our sites. In terms of the timing, we've been working quite closely over the last couple of months with NHS England, which is the sort of national commissioning body, who are giving us some advice and guidance on the submission of our business case to get those capital funds for the redevelopment of our sites.
Is as you get older, you become iller. Most of us. And it would seem, maybe I'm wrong, that hospitals and experts...
Can you keep the microphone close to your mouth?
Yes, I'll put it in. That the experts say, okay, we cannot do anything for you, go home and die. Now, I don't know whether you agree with that, but that is in fact reality. That they say, nothing we can do for you. And also, you don't go into hospital to die. That's not not the point of a hospital. It's not a holy home or whatever. I leave it with you, please.
Thank you very much for the question. I completely agree with you that sometimes the hospital is not the most appropriate place to provide lots of treatments. and one of those is managing patients who unfortunately will be dying. And we need to make sure that we're working with our community partners very closely to ensure we're delivering the care in the best possible environment for each individual patient. I agree with you that we're getting older, and that's myself included, and we need to look to the future to make sure that we're providing the right services for those patients who are getting older and will have not just more chronic illnesses, but more combined illnesses. And we need to work together to ensure that we're healthier as a whole population, so that we're not reliant on a hospital to reach us when we're ill, but we're taking more proactive measures ourselves to ensure that we are as healthy as we can be, and the hospital is there to help us when that isn't possible and we have an illness. I hope that answers your question.
Not quite.
Who've had to move to Charing Cross, which is not convenient for me. I saw them about 5 weeks ago, spent a day there for 2 procedures. Since then, I have heard absolutely nothing. There are 2 alternatives for treatment. I've heard nothing. I actually took the trouble to write to the senior consultant myself to say to my doctor, doing it. And I've heard nothing. I am in limbo, rather like the gentleman in front of me. And I really don't know what to do next.
I think perhaps the best thing we could do is get one of our staff to catch up. Can't hear. Is my microphone on up the back? Can you hear me now? Great, thank you. I think perhaps the best thing we could do is if we could take your details, we've got some people around in the audience, we'll get your name if we can, and we'll follow up directly for you after tonight's meeting. Thank you.
Particular interest in the financial side of the trust. I notice that £123 million of a rather strangely an increase in an impairment is in fact needed to produce a profit of £15 million in this year, strangely very similar to the previous year. I'm concerned that overall the presentation of the accounts is so obscure and so badly explained as to be meaningless. And this leads me on to question what is going to happen in 3, 4, 5 years' time when you may or may not achieve Foundation Trust status. You may or may not have further impairments, if I can use that term, to your Care Quality Commission reports. In 5 years' time, which one will be most important? A CQC very glowing report or trust status, a Foundation Trust status? Thank you.
Yeah, I was told to use this mic. Is that carrying okay? Yeah, thank you. First, thank you very much for the question. Secondly, it might sound strange, but I'm inclined to agree with you about some of the hoops we have to jump through in order to present the numbers. I'm of a rather simple accounting type, as you see from some of the slides I present, where I try and keep it as clear as possible. Unfortunately, under something called international financial rules, we are obliged to treat some things that I would think of as rather technical accounting, which is 123 million. We have to both show that sort of in the income and in the expense. So your conclusion that it was necessary to produce a surplus isn't actually quite correct. But in terms of the way technical accountants look at it, that is the way we present it. There's a little summary at the bottom of that table that does try and show a rather cleaner view that most of us understand in terms of income less expense equals surplus. So I can assure you that the income less the expense does give you a 15 million surplus in the way that most of us would recognise. I'm afraid I'd have to get extremely technical to explain all about the land revaluation, and then I'd have to try and explain exactly why it's presented that way, and even I would struggle. So I'm inclined to agree with you about the presentation, but the board relies for its running of the trust on the way that we were presenting the numbers with that rather simple income and expense. I'm very happy to talk to you afterwards about the nature of accounting impairments and the revaluation of our land, which does drive that 123 million. Happy to take you through that, but it is not particularly pertinent to actually understanding the profit and loss situation. Your second part of the question was also an interesting one in terms of looking 5 years forward. From my perspective as CFO, I'm very clear that CQC and patient care outweighs the sort of financial issues every time. And that's very much the way I would expect the board to focus issues, that it's first and foremost patient care, and then trying to keep us sustainable financially, by which I mean having enough money to continue to treat patients in the same way into the future. So we have to be financially responsible, but in no sense are we driven towards sort of maximising finance over patient quality at any time. But perhaps others on the panel would like to expand on that further.
Richard has just made, and the particular thing that the Foundation Trust people look at is not just financial sustainability. Maybe in the past that was how Foundation Trust status was sort of looked at initially, but these days it's very much looking at three things. What's financially sustainable about the organisation that's being assessed? What is the quality of care that's being delivered? And that's the bit that the CQC looks at. And then what is the governance of the organisation? How is the organisation led? So it's all three elements that get assessed when an organisation is looking to move down the pathway of Foundation Trust. And when you think about delivery of quality patient care, for me, quality of care and the efficiency with which we deliver that care are very much two sides of the same coin. They tend to go together. If you can deliver your services as efficiently as possible, it tends to deliver the best quality care for our patients, and that's what we look to do each time. Forgive me if I haven't got all elements completely down pat, but firstly I would like to echo your starting remarks and your ending remarks. We're only as good as the 10,000 staff that work with us every day, and you're quite right, we have a fantastic group of staff that work across each of our sites. So I think you're quite right in recognising the great work that they do every day. And we would be lost without our charity. We have our charity represented here today with Ian Lush in the audience, and they do fantastic work, and volunteers that work with us do fantastic work every day as well. So I'm really pleased that you highlighted both of those for us. You raised a number of particular questions. Some were about our IT, and we are very lucky to have our CIO in the audience. He's delighted that he's been highlighted in the second front row here. So just while we're getting a microphone to him to talk about some of the IT, it might just be worth talking a little bit about weekend work and 7-day work, which is something that you did raise. And you'll know that there's been quite a lot of press and quite a lot of media about how we move our hospital services, how we move the NHS from what has traditionally been a sort of Monday to Friday 9 to 5 service. Now it's changed a lot since those days, but we still are away from being a truly 24/7, 7 days a week service. And that has all sorts of implications in terms of how we think about staffing our facilities, how we think about staffing our facilities safely 7 days a week so that we can provide that sort of consistent level of care. But one of the things that we have been working on to try and get our waiting times down is exactly that, doing weekend work. So where can we look to put on either weekend operating lists or additional outpatient sessions to try and get our waiting times down, not just for our cancer patients, but for any of our elective patients, so that we're hitting each of those standards. And as I highlighted in the presentation, we're now hitting the 92% standard for the 18-week wait. Over the course of the last 12 months, we've done quite well in terms of hitting our cancer waiting times. So if there is a particular area that you're waiting for, again, what we might do is ask one of our staff members if we can take your names and details. If there's a particular, I think it was injection you said that you've been waiting for a long period of time, it might be worth taking that offline so we can understand what that is and what the delay is so that we can deal with that for you. So I'll get one of the staff to come up to you at the end of the question time. But if I could just ask Kevin, who's our Chief Information Officer, just to talk a little bit about what we've been doing with our IT systems. Sort of damned if you do and damned if you don't with IT, but we do know as a health service that we absolutely need to continue the move towards paperless systems. So Kevin.
Hi, so can everyone hear me? So I'm Kevin Jarrett, I'm the Chief Information Officer, and we're going through a process of modernising our IT systems. And we've been having the kind of challenges that everybody has when you bring in new systems, and that people have to take time to learn to them and time to adapt. We're also aware that the patient experience of interacting with our outpatients in terms of the process by which we get the letters out has not been as good as it could, so we've got a whole process looking at how we can drive improvement through that entire process across the organisation. So my team on the IT side work very closely with Steve McManus's operational teams. We've got a whole improvement challenge that we're taking forwards, which is looking at the beginning of the process, so how we get referral letters in from GPs, right through the process to the discharge letters that go out to tell GPs what we've done. And our ambition is to have that whole process digital. At the moment, there's a lot of interaction that takes place with paper and there's various handoffs, and we're looking to streamline that. So that's the agenda that we're driving forward. In terms of the specific issues, if you've got a particular problem, if you want to approach me afterwards, we can get that looked into and see what we can do to fix it. Thank you.
Thanks, Gavin.
A patient representative on the user panel of the Central London CCG. And I notice that you are articulating something that all of us support, which is to provide integrated models of care with our partners to improve the health of the communities we serve. And that's, of course, also what the CCG wants to do. My worry is, how are you going to provide integrated care when there are declining numbers of GPs in London, people taking early retirement because they're finding it too stressful, and now the government wants them to work 7-day weeks, which is, in my view, crazy. They're already overworked and marvellous people. There's a shortage of community nurses, and the local authorities on whom you need to rely for care are subject to decreasing rather than increasing budgets. As Polly Toynbee pointed out recently, the main problem for Addenbrooke's Hospital, which is a very similar organisation to yours, is a shortage of beds, both absolutely and because there is nowhere for patients needing out of hospital care to go. And as an add-on, I just want to say, how are you going to staff the hospitals, the nurses and community care people and so on, if house prices continue to rise in this part of London and you are doing nothing to contribute to housing your staff in the new plans that you have for St Mary's Hospital area?
So thanks very much for raising that question about integrated care. It's obviously an area of absolutely vital importance, and I don't think we can just think about the healthcare system by itself. We really do need to think about the health and social care system, as you've raised. The community independence service that we're piloting this year is doing exactly that. So the providers that we've got around the table, and we had a Better Care Fund, what it's called, last night, where all those providers were there, is talking exactly about how we get better integration between our healthcare system and our social care system. And in thinking about our healthcare system, it's not just the acute part of the system, it's the community part of the system, it's the primary care part of the system, and the mental health part of the system. There are all sorts of anachronisms between how we run the various parts of our systems, and some of the things that we were looking at together last night, just to give you one example, was about how we discharge patients from our hospitals currently, and depending on which locality you live in, so you might be a patient in St Mary's Hospital, but you might actually live in Brent. The way we discharge you if you live in Brent is different from the way we discharge you if you live in Westminster. It's a different process, it's more difficult for the hospital to achieve, and it's more difficult for the patient and their family to get discharged. Now that is crazy, because people that come to use St Mary's Hospital do not just live in Westminster, They live in Brent, they live in Kensington and Chelsea, they live in Hammersmith and Fulham, some of them live in Ealing and elsewhere. So one of the things that we are doing, and it gets to the question of integrated care, is working very closely with our partners to say, how do we make it one discharge process so that no matter where you live, no matter what borough you live in, you have the same way of being discharged if you live in Brent as if you live in Westminster. There's just one example of how working together we can run our health and our social care services much more efficiently than we're running them at the moment. The other part of your question was around housing, and housing really is a key concern for our boroughs, and certainly it is an area that we're well aware that Westminster Council is very much focused on how to get much more affordable housing within the local borough area. So that is
Okay, well thank you very much for your questions.
It's fantastic to see the stuff that can go on at the campus. I just wanted to make the point that the campus is situated in the middle of an area with very high health inequalities. Lots of things that relate to heart disease in the local population, literally around White City, high smoking, high obesity, high heart disease, high lipid, high diabetes, early mortality, you name it, around there. And what I suppose I'm putting a plea in is that in this fantastic work that's going on at the top at this very high level, and I know it's not just your responsibility, but talking to Imperial generally, can we try to make sure that some of those benefits directly transfer to the local population? Because it's kind of frustrating that Hammersmith Hospital is such a world centre in so many ways, and yet the local population has relatively poorer health than most of London.
Well, absolutely. Yes, absolutely. And in terms of several things, in terms of being first in for the clinical trials, well, that population would be the population, and we'd be asking if they would like to come into the clinical trials, obviously our local population. In terms of, one thing you could say about these therapies is, are they going to be incredibly expensive? And it's difficult to know, and probably at the beginning they may be, but things like the circular gene therapy, for example, with a single injection, actually ought to be, in the end, a lot cheaper than the things that they're doing at the moment. And so wouldn't only go to very small amounts of patients. It should be something that we could roll out. Maybe a while, of course.
I'd like to thank the Venue AV team, to all the staff who've helped to organise this evening, to our staff and partners on the stands that have given up their time so gratefully, and a thanks to all of you for taking part and for your questions. It's very important for us to know how you found this evening. I think last year, you'll notice that this year is very different. It's very different because we got feedback from you about many things. So we've changed as much as we possibly can to accommodate your comments. We'd love to get your comments again because we want to do the right thing for you. We want you to come here to enjoy the evening and feel that you're really understanding what we're trying to do in the Trust. If you'd like to stay a little longer, we have our staff around. We have physicians here, clinicians, technicians, nurses, lots of people. So if you have questions, if you have problems, please don't hesitate to contact them and talk to them. It's your opportunity. And then, of course, we will publish the proceedings of the AGM on our website. So again, thank you all very much for coming this evening. It's been a pleasure to see you, and I hope you've enjoyed it. Thank you. Thank you.